One cancer where precision oncology has made a dramatic difference.
Lung cancer.
Acha.
So, as genetics as a cause of for all patients, but it is to be done in selected population patients in whom more than one cancer has been detected. There are multiple family members. Even though the proportion of patients receiving chemotherapy is going down day by day, I would still say chemotherapy forms a backbone of some of the malignancies significantly.
One advancement in oncology that excites you the most today.
Yes, in the form of targeted therapy that is called as ADC,
Acha.
antibody drug conjugates, that are coming up in a big way in patients who have progressed on chemotherapy, targeted therapy, even immunotherapy. These ADCs, that is antibody drug conjugates, are found to be effective.
Great. Cancer is no longer just a battle of survival. It's becoming a story of precision, possibility, and hope. From one size fits all chemotherapy to therapies designed for the individuals, the landscape is rapidly transforming. But with breakthroughs like targeted therapy, precision therapy, immunotherapy, comes questions, new expectations, and new uncertainties. Why do some patients see dramatic responses while others don't? Are we truly moving towards making cancer a manageable chronic condition? Today, we explore the science, the myths, and the future that is quietly redefining the cancer care. It's a privilege to have with us today Dr. Shrinivas Kulkarni, a highly regarded medical oncologist known for his expertise in advanced evidence based cancer care. He is currently serving as consultant in medical oncology at Sahyadri Hospital, Harapsar. Dr. Kulkarni has a strong academic foundation with an MBBS from ACPM Medical College, DNB in internal medicine from Jahangir Hospital, and a super specialty DNB in medical oncology from Manipal Hospital, Bengaluru. His clinical expertise spans wide spectrum of solid and hematological malignancies including breast, lungs, gastrointestinal and blood cancers. He is also trained in precision oncology approaches incorporating targeted therapy, immunotherapy and advanced treatment modalities to optimize patient outcomes. Recognized for his balanced approach and clear communication, Dr. Kulkarni is committed to delivering holistic cancer care that prioritizes both treatment efficacy and quality of life. Welcoming Dr. Shrinivas Kulkarni. Hello and welcome to Sahyadri Health Talks. I'm Dr. Tushita and today we have with us Dr. Shrinivas Kulkarni. Hello,
Hello,
sir. How are you?
I'm fine. Thank you.
Welcome
Yeah,
on Sahyadri Health Talks.
thank you.
And we are super excited to have you today because after a really long time, we are going to have some discussion on oncology. And but before I jump into that, so 10 years, 10 plus years, I believe,
Right,
right, of
right.
dedicated practice given to oncology. So you must have seen the transition and the rapid, progress that oncology, especially the medical oncology field, that
Right,
has made.
right.
So, tell us about it. What kind of a difference do you feel in managing and handling the patients in terms of their treatment 10 years back when you started versus now? How is it?
Right. So I have really witnessed actually a transition in terms
Yes.
of management of cancer patient. When I started my undergrad training,
Uh-huh.
and it was like a treating cancer patient as a blanket treatment. Majority of the patients usually end up in taking chemotherapies, but
Yes.
now over a period of time in last 1 decade, we are slowly moving away from a blanket treatment
To
to
more
something
precise,
called as personalized treatment or customized
customized treatment.
treatment. And
Yes.
this is something fascinating for
Mm-hmm.
me. And I still believe, I remember the lines from my head of the department when I joined the training.
Mm-hmm.
Srinivas, by the time you will pass out
Uh-huh.
or you start practicing, the
Uh-huh.
oncology would have gone to a different level. And today I'm experiencing the same.
So yes, so we have heard so much. I mean, all this while, over the last 10 years, the kind of development that has happened from the chemotherapy aspect of the medical oncology,
Right.
which was more kind of a I think carpet bombing is what it is called as, to precision oncology, targeted therapy, immunotherapy, which are like extremely precise form of
Right.
therapy. So we believe that these are more kind of customized for
Right.
each patients.
Right.
How far, or rather how close are we to implementing this for each patient that we see?
Right. So as I told you that we have moved away from a blanket treatment to
Yeah.
something called as precision oncology.
Yes.
This precision oncology is nothing but an overarching
Acha.
tailoring strategy,
Mm-hmm.
in terms of finding out what is happening at a DNA level of a tumor
Acha.
with the help of something called as molecular profiling.
Acha.
It helps us in choosing the best treatment.
Mm-hmm.
And the precision oncology includes targeted therapies, immunotherapies,
Acha.
either in alone or in combination, which not only improves the oncological outcomes but
Mm-hmm.
it also maintains the quality of life of the patients. And
Mm-hmm.
we know that when the patients used to be on chemotherapy, the quality of life, used to go quite significantly
Yes.
down. But
Yes.
with recent advances in oncology, we can clearly see these treatment options not only treat the patients efficiently
Mm-hmm.
but also maintains good quality of life by
Mm-hmm.
prolonging their life.
So help us understand about this targeted therapy, right? I mean, how different it is from the conventional chemotherapy.
Right, right. So conventional chemotherapy, we know that it acts by killing the cells, and
Yes.
it kills not only cancer cells but also healthy cells.
Mm-hmm.
And we see that the majority of the side effects of chemotherapy are not because of killing of the cancer cells, but they
Mm-hmm.
are because of the killing of healthy cells.
Mm-hmm.
Now, how this targeted therapy is different from conventional chemotherapy is that, suppose you take any particular cancer, so we choose one cell, and there are certain antenna over the surface of the cell.
Receptor kind of
We
a
often
thing.
call it as receptors.
Mm-hmm.
And whether that particular cancer bear those receptors or no,
Mm-hmm.
based on that we can choose a targeted therapy to be added
Acha.
in our treatment armamentarium. And it additionally gives a leverage
Mm-hmm.
to the treatment in terms of response rates, achieving more and more durable
Mm-hmm.
responses, making the side effects less with good long term outcomes.
Mm-hmm.
So targeted therapy is nothing but finding out the mutations
Correct.
in particular tumor subtype. So it
Mm-hmm.
is just finding out the tumor genetic profile
Mm-hmm.
and finding out the tumor characteristics, understanding them, and choosing a treatment option which can specifically target those cells which have these kind of receptors or the antenna.
Mm-hmm.
It not only helps in treating the cancers in a better way
Mm-hmm.
but nullifying the side effects
So
associated with
basically, the
conventional.
collateral damage is very less
Absolutely, and
or
that is
nil.
absolutely, and that is something, a real beauty of these targeted therapies
Mm.
that we are using in practice. And
Mm.
coming to the last question, are we near the reality of that?
Mm-hmm.
We are actually into a era where we are dealing with precision oncology, targeted therapies, and immunotherapies day in day out in our clinical practice.
Mm-hmm. So we are almost handling every patient as a
Absolutely,
customized
absolutely.
way of treatment.
So cancers of two different organs are different, we completely understand, but even cancers of same type, suppose two breast cancer patients was sitting besides each other, they are
Uh-huh.
also different
Different.
biologically.
Correct, correct. So when it comes to the targeted therapy, right? As you said that there is a set of process which are done, molecular testing and all are done, and then we uh, do the targeted therapy.
Right.
So are there any key factors that determines कि आप किस पे ये targeted therapy? I mean, which are the patients who are suitable for this, and how do you decide on that part?
Absolutely. Whether you talk about targeted therapy or immunotherapy, हमारे पेशेंट में इधर टारगेटेड थेरेपी या इम्यूनोथेरेपी एलिजिबल है क्या, ये जानने के लिए हम सबसे पहले करते हैं एक मॉलिक्यूलर प्रोफाइलिंग टेस्ट।
अच्छा।
उसको बोलते हैं CGP. It is
हम्म।
nothing but a comprehensive genomic profiling,
अच्छा।
and it is done by a technology which is called as NGS, that is called as next generation sequencing. हम कहते हैं ना किसी की कुंडली देखना, तो ये CGP is nothing but to see the कुंडली of the tumor.
अच्छा।
So what it tells us, any genetic abnormalities that are driving the cancer at DNA level,
हम्म।
we can pick it up.
हम्म।
And the important implication of this is that if one particular cancer is being driven by
हम्म।
some genetic abnormalities, we can specifically target the genetic abnormality either in the form of tablets
Mm-hmm.
or by giving some intravenous medications, which is nothing but the targeted therapy. And immunotherapy is something which we always look for patients eligibility for immunotherapy
Acha.
by doing certain tests on the tumor tissue blocks,
Hmm.
and these tests are called as biomarkers, and it
Acha.
tells whether immunotherapy will be effective in this patient or
Hmm.
no.
Acha. So, in case of immunotherapy, we have seen, that some of these immunotherapies works does wonders in
Absolutely
some patients, but unfortunately, few of the cases we don't see that
right.
much, success rate when it comes to
Right.
immunotherapy. So, help us understand why this discrepancy.
Absolutely. As I told you, we have to first see the eligibility of a patient for the
Correct.
immunotherapy.
Correct.
There are various studies that tells us the numbers regarding the utility of immunotherapy in various cancers.
Mm-hmm.
So there are studies which will tell us that immunotherapy will be effective in 15 to 30% of the patients. There are studies which will tell us that it will be effective in
Mm-hmm.
20 to 50% of the patients. But immunotherapy is not a cup of tea for
Mm-hmm.
all patients. It
Correct.
is basically a cup of tea for only for, I would say, 15 to 30% of the
Mm-hmm.
patients who become eligible
Mm-hmm.
based on the assessment of biomarkers. So we do test some biomarkers mainly in the form of PDL1, MMR testing, or tumor mutational burdens, which will tell us whether the patient will be benefited with immunotherapy or no.
Okay. So, what is the what is the role of early and acute profiling when it comes to the molecular testing part of it?
Absolutely.
So,
So it has become a rule nowadays
hmm.
to do this kind of comprehensive genomic profiling, especially in advanced malignancies. We do these CGP panels
Mm-hmm.
right in the first place
Acha.
when we are planning for the treatment of such kind of advanced or the stage
Hmm.
4
Hmm. Hmm.
diseases, because it not only help us in
Hmm.
understanding the responsiveness
Hmm.
of the patient's tumor to a given treatment,
Hmm.
but it also helps us in prognosticating the disease, because
Acha.
certain mutations are there which can give aggressiveness to the tumor, recurrent tendency to the tumor, that we need to keep in mind.
Hmm.
So for all advanced or the stage 4 cancers, we
Hmm.
do this kind of genetic profiling upfront.
Hmm.
And for those patients which are early,
Hmm.
not in all cancer patients but in certain subset of patients, we do end up in doing genetic profiling even in early diseases such as stage 1 and stage 2. But yes, it is a rule that we have to do this kind of genetic profiling tests in advance of the stage 4 cancers right in the beginning.
Mm-hmm. So, overall, the term cancer, is quite intimidating, to be
Absolutely.
honest. And though we, as a medical, coming from a medical background, we do understand where the treatment perspectives are today and how successful they are. But when it comes to talking to a patient, so I'm coming to the counseling part right now,
Absolutely.
right? So when it comes to counseling the patient, first of all, it's quite shaking, it's quite disturbing for them, I would say
Absolutely.
that, diagnosing with cancer. And then comes, you have to explain them with these newer therapies.
Right.
So most of, I would say, Indians, we have this mentality or somewhere the fear that these are new treatments which are being tested on us.
Correct.
So it gets a little complicated and difficult. So how do you
Absolutely.
manage telling patients that these newer treatments and are very safe, or for that matter, what message do you want to give out to all the audience who are listening to us now,
Absolutely.
that these treatments are safer, and what should they be not worried about when it comes to this newer
Absolutely.
therapies?
So basically, we need to understand, the fear that the patients have in their minds when they are diagnosed with a cancer. Uh, First of all, they are not worried much about the cancer, but they are much worried about the treatment parts, especially when they listen that you have to receive chemotherapy.
Hmm.
Now, because of this precision oncology, targeted therapies, and immunotherapies, the things have become more complicated for us actually. And for the patients to understand all these things, I always follow in my practice communication and
Hmm.
educate the patients.
True.
I always say nothing in life is to be feared, it is to be understood.
Hmm.
So, right from the beginning, we need to talk to the people, and people are scared. They're not aware of.
Hmm.
If you tell them not completely or 100% what they want to listen or they want to receive, uh, it becomes very easy for them to accept if you
Hmm.
give some hint or some idea ki what is the plan and what your plans are going to be. Now
Mm-hmm.
if you're particularly talking about these targeted therapies and
Hmm.
immunotherapies, believe me, the problem in Indian context is
Hmm.
actually the finances
Hmm.
associated with these
With this
targeted therapies
targeted
and
therapies.
immunotherapies. But we all know that any treatment that comes first, it is costly, but over a period of time it becomes cheaper. So
Mm-hmm.
our challenges start from the finances. Even if you tell the patients
Hmm.
regarding all the things, whether
Hmm.
the patient is going to be affordable for that particular targeted therapy or immunotherapy is the
Hmm.
biggest challenge.
Mm-hmm.
Second thing comes to convince them to
Yes.
take the treatment. So the next question that the patients put us is
Hmm.
basically, now we are spending so much of money on the targeted therapies, are we going to get the similar kind of results from that?
Yeah.
See, I always say that 2 plus 2 is not always equal to 4. It
Hmm.
becomes either 3 or 5.
Hmm.
The next best thing for you is this.
Hmm.
And if you don't take it, if you want to take it conventional chemotherapy, the advantage is going to be like this.
Hmm.
And if you add a targeted therapy and immunotherapy to the conventional chemotherapy,
Hmm.
the magnitude of benefit is going to increase by
Yeah.
this much. So this is
Yeah.
something which we try to make them understand.
Mm-hmm.
And more importantly, this treatment, additional treatment, especially targeted therapies
Mm-hmm.
and immunotherapies, they are not additionally going to compromise
Hmm.
quality of life of the patient. Is something which is very important for the patients to learn.
Hmm.
So financial challenges, second therapeutic challenges, toxicity challenges, effective challenges, all these challenges can be overcome by educating the people and by communicating with them what we are going to do or plan for them. So
So
I
basically,
always
the
use
transparency.
absolutely transparency. And uh, you have to spend time with the patients.
Correct.
You This might be a regular thing for all of us in
Uh,
OPD day in day out, but patients are suffering for the first time and they need to understand these things.
so now that we are seeing so much of advancement with precision oncology, targeted therapy, and immunotherapies, coming in picture, uh, can we say that in coming future, cancer will be more kind of a chronic disease with which we will have to learn to live with, like how we are living with diabetes, we are living with blood pressures, hypertensions. So, do we see the future there?
Absolutely. It means I think you have highlighted very important point. And with this kind of targeted therapies and immunotherapies, we have patients who are on targeted therapies and immunotherapies since last 5 years, six
Uh,
years, and to start with, they were diagnosed with stage 4 disease.
mm,
Without these targeted therapies and immunotherapies, if the life expectancy would have been like in few months,
mm.
they are living for years
Years
together.
together.
So what we have done actually is to convert these active diseases
Mm.
into a chronic form
Uh-huh.
and continue the ongoing treatment as a maintenance strategy.
Acha.
Yes, of course, I'm completely in line with you in terms of putting it forward.
Uh-huh.
If we are converting these active diseases into a chronic form so that they will be like a diabetes or hypertension,
Uh-huh.
patient needs to keep the treatment and keep them under control
Uh-huh.
and can go on for years.
What about the quality of life? I mean, see,
Absolutely.
we are increasing the quantity. I mean, the
Correct.
days are from
Correct.
months, it is going to years, right?
Correct.
So, what the next fear is that uh, I will be suffering like this for years together.
Right.
उससे अच्छा है कि खत्म करो बात, right? So, what do you have to say for these patients who think like this?
Right. So, as the name suggests, it's a targeted therapy or a precision oncology. It specifically targets the tumor cells, sparing the healthy cells. And as I told you earlier, that majority of the side effects of cancer-related treatments are
Hmm.
because of affection of normal cells. In targeted therapies or in precision oncology medications, your healthy cells are spared.
Spared.
So only specifically targeting cancer cells will keep the patients in good quality of life.
Hmm.
So this is the beauty of all these recent
All the
advancements and
recent
targeted
advancements.
therapies and immunotherapies.
What is the most common misconception you have heard about advanced cancers in patients?
So the most common misconception that I have heard about advanced cancers is chemotherapy is the only treatment of choice.
Acha.
So let me tell you something. There are many advanced cancers which are diagnosed on day one and we are not giving them chemotherapies at all.
At all.
We are treating them even with simple tablets which are easy to tolerate, can be taken at home. So
Acha.
the most common conception is that the chemotherapy is the only treatment of choice for advanced cancers. Believe me, this is not at all true. With personalized medicine, with customized medicine, we are slowly moving away from blanket treatments. And earlier we used to say one size fits all, and this
Yes.
is something is proving wrong nowadays with
Nowadays.
the advent of targeted therapies and immunotherapies.
So, what excites you in the near future the most? I mean, we have precision therapy, targeted therapy, immunotherapy, and I'm pretty sure there are many more which are,
Correct.
coming up.
Correct.
So, what is that one thing which excites you most? That if this comes, then my approach to the treatment and the patient care will be, a completely changed approach. What excites you the most?
So, as we are talking about targeted therapies and immunotherapies, there is something called as detection of CTCs. It
Acha.
is called as circulating tumor cells. When
Acha.
the patients are on treatment with
Uh-huh.
these kind of newer
Uh-huh.
agents, there are tests which detects the
Acha.
recurrence of the tumor before it affects the patient
Uh-huh.
or before it becomes evident on the scans or
Acha.
imaging. So
Acha.
we can keep a track of these circulating tumor cells every time, and we can measure this circulating tumor size. And those patients who shows changes in these circulating tumor cell pattern, they are at higher risk of developing tumor progression or increase in the disease burden in future. This is something quite fascinating. Like, you are able to predict which patients are going to do fine and which patients are not going to do fine without any scan or without any fancy or heroic test. It is called as CTC detection, which is a simple blood test.
Arre wah. So that would be, I think, one of the major breakthroughs which we can see in the future.
There are caveats, there are drawbacks actually.
Uh-huh.
Even though it cannot be generalized at
Acha.
moment, these tests are financially challenging, especially in Indian context. Patients are not even affording the treatment when they will be able to do all these things. This is something, but yes, it will come up in a big way in future, and probably this is a game changer.
Okay, sir. So that's about the future of oncology, medical oncology, to be precise. Now, before I move to the next segment of my podcast, I just want you to re-emphasize on the role of immunotherapy in cancer
Right.
treatment, right? Because we spoke about targeted therapy. I mean, initially started with the precision therapy, and then targeted therapy. What does exactly this immunotherapy does? I mean, what is
Right,
it?
right. See, our body has immune system,
Hmm.
and it is composed of something called as tumor suppressor genes also.
Mhm.
But not all patients develop cancer. There are only few subset of patients who develop cancer. See, cancer cells are very smart cells.
Acha.
They keep themselves hidden
Mm-hmm.
from the immune system of the body, and they keep growing.
Acha.
And they do this by something called as continuously changing nature of the tumor or the mutations.
Hmm.
So our immune system is not able to identify those cancer cells as foreign cells,
Acha.
so they keep growing.
Acha.
What does this immunotherapy does?
Mm-hmm.
It makes our immune system recognize those cancer cells as
Acha.
foreign
Acha.
and specifically target them.
Acha.
This is called as immune augmentation.
Acha.
So in contrary to the chemotherapy, which acts by killing the tumor cells and
Hmm.
healthy cells,
Hmm.
immunotherapy acts by immune augmentation.
Acha.
It enhances body's immunity.
So basically, it makes it more strong so that you
Strong,
can see
absolutely.
the immune system can see those particular hidden
Absolutely.
cancer
Cancer cells
cells.
as foreign and
Acha.
specifically target them rather than targeting associated healthy cells.
Oh.
So immunotherapy works by immune augmentation, stimulation of immune system,
Mm-hmm.
and not by killing the cells. So the side effects which we commonly see with chemotherapeutic agents,
Mm-hmm.
they are not at all seen with immunotherapy agents. And
Mm-hmm.
we are currently practicing immunotherapy even for the patients, aged patients
Mm-hmm.
whose age is 80, 85, 90,
Mm-hmm.
by maintaining the quality of life.
Oh, great. Okay, that's all about the modern or advanced medical oncology. Now, moving to the next part of our podcast, which is I'll ask you a few questions. It can be a myth or a fact, or some common questions which are frequently asked. So let's do this once and for all. Targeted therapy has no side effects. Is it a myth or a fact?
It's a myth. Because it's a targeted therapy, it does have specific side effects regarding the target that it is affecting, but you can definitely manage the side effects by consulting your own physician.
Okay. One factor that most strongly influences responses to immune therapy.
Biomarker assessment. As I
Acha.
told you, we test few biomarkers on tumor tissue which
Mm-hmm.
will tell us the eligibility of the patient for immunotherapy.
Mm-hmm.
So biomarker assessment should be done upfront in all the patients who are likely to be eligible for immunotherapy.
Immunotherapy. Immunotherapy works for all cancers. True or false?
False. It doesn't work for all patients. It works for 15 to 20% of the patient to the fullest extent in whom the biomarkers are positive.
Hmm. One cancer where precision oncology has made a dramatic difference.
Lung cancer.
Acha. Because I think it is mostly diagnosed at a very advanced stage.
Absolutely.
So,
Yes.
precision oncology.
Yes.
Genetic testing essential for all patients or only for selected cases?
So, as genetics as a cause of cancer is seen in roughly around 20% of the patients, it is
Hmm.
not indicated for all patients, but it is to be done in selected population patients in whom more than one cancer has been detected. There are multiple family members have been
Acha.
affected, cancer occurring at young age.
Mm-hmm.
So, there are selected subset of patients in whom genetic testing should be advised.
Mm-hmm. Newer therapies always replace chemotherapy. Myth or fact?
I would say it's a myth. Even though the proportion of patients receiving chemotherapy is going down day by day,
Mm-hmm.
I would still say chemotherapy forms a backbone of some of the malignancies significantly.
Mm-hmm.
In some of the cancers, chemotherapy is still a common denominator, and on top of that, we add medications of precision oncology in the form of targeted therapy or immunotherapy.
Mm-hmm. Mm-hmm. One limitation of targeted therapy people rarely talk about.
Uh, Currently, to start with finances.
Financial thing is
Absolutely, that is
always
something. And
a
targeted
constraint.
therapy limitations as such, I haven't come across anything specific.
Mm-hmm.
But to start with, finances are involved. That is something, a limiting factor for all of the
Hmm.
clinicians.
Not, and also for many patients, not everybody can go to that level to afford it.
Absolutely, absolutely.
Okay, if one treatment fails, nothing else works. True or false?
Uh, False, because there are newer and newer treatment strategies that are coming up. So if first line fails, you always have second line, you
Hmm.
always have third line, you always have fourth line. So this is a myth that if one treatment fails, nothing is going to work. You always have second chance.
One advancement in oncology that excites you the most today.
Yes, in the form of targeted therapy that is called as ADC,
Acha.
antibody drug conjugates, that are
Hmm.
coming up in a big way in patients who have progressed on chemotherapy,
Hmm.
targeted therapy, even immunotherapy. These ADCs, that is antibody drug conjugates, are found to be effective.
Great. Last word. In one word, what does the future of cancer look like to you?
I'm quite optimistic.
Mm-hmm.
Patients are living longer,
Mm-hmm.
uh, not only in terms of getting treated, but
Mm-hmm.
maintaining quality of life.
Quality of
But
life.
yes, future is bright.
So before we let you go, we have a ritual. This is Sahyadri Health Talks ritual, where we get to hear some stories from you, a patient story which is very close to your heart and has left a mark in your heart. So share some stories with us.
Right. So recently I came across one young gentleman, IT software engineer, 40 years old. He was evaluated outside for continuous headaches and ended up in finding actually nothing. Evaluated in details with PET scan and other thing, found to have one small lung tumor, as well as the coverings of the lungs were also affected. This
Oh.
is called as leptomeningeal disease, and a few nodules in the brain as well. So
Hmm.
the picture was suggestive of lung cancer which has gone to the brain
Mm-hmm.
and leptomeningeal involvement. To be very honest, maybe 15 years back, 20 years back, when the effective treatment strategies were not available, the
Hmm.
life expectancy would have been in months, 4
Hmm.
months or 6
Hmm.
months.
Hmm.
Because of his young age and non-smoking kind of a status, we suspected that this patient must be having some cancer which is being driven by some genetic abnormality,
Acha.
and we anticipated that, and biopsy was done, found to be lung cancer which is of adenocarcinoma type. We always do these kind of comprehensive genomic profiling lung cancer panels in these patients, and we found out one mutation in the EGFR gene.
Acha.
And probably that was driving, not probably, actually that was driving the cancer at his
Mm-hmm.
age,
Mm-hmm.
without any smoking history. And
Mm-hmm.
believe me, we started him on targeted therapy which is anti EGFR,
Acha.
which goes to brain, which also takes care of leptomeningeal diseases, that is called as osimertinib. And believe me, that patient is who was actually bedridden when the patient came to us,
Mm-hmm.
and now he walks, he comes to OPD on his own without support, and he's actually continuing his life normally.
Mm-hmm.
So this is something fascinating, and there comes a role of precision oncology. If he would have presented to us maybe 15 years back, 30,
Mm.
20 years back, we wouldn't have, that kind of effective treatment. But
Treatment
yes,
line.
today is, even if these patients have stage 4 lung cancer with brain metastasis and
Ah,
leptomeningeal diseases,
ah.
such kind of genetic alterations can be very useful.
And we can retrieve the patient back from
Absolutely,
there.
with help of one tablet a day.
Yeah,
I think that is
that's
something
beautiful. That's the
absolutely
beauty
fascinating.
of this entire precision oncology.
Absolutely, absolutely.
That's a beautiful story to hear about, and we wish you all the best for all your, future endeavors, and may many more patients who need the
Absolutely.
right line of treatment
Right.
reach out to you. So before we end this podcast, any last message for all our viewers? Maybe somebody who is already fighting cancer, or a family member who is dealing with the patient in the family who has a cancer. Any closing message for
Uh,
them?
yes, I have already told that, nothing in life is to be feared of, it is to be understood. So diagnosis of a cancer doesn't mean a death sentence. There are newer and newer treatment options which are treating cancer in a better way by maintaining quality of life. So you please, please, please go by the advice of your treating physician, uh, and believe it and continue with the treatment. Because what happens, unfortunately, uh, social media is being, used quite rampantly by the patients and
Yes.
relatives. uh,
Yes.
and I always feel the information provided by such kind of platforms is a two
Yes.
dimensional information, and patients or the relative should not interpret it the way they want.
They want to.
Please go and meet your physician and get treated effectively and in a better way. Thank you so much.
So, on that note, don't Google your symptoms. Don't
Absolutely.
Google your problems. Go and talk to your doctor about it, and get a more, detailed, accurate, and correct information about
Yes.
it. Right, sir?
Yes.
On that note, this is Dr. Tushita signing off. Sayadri Health Talks.